Okay, so I can't really see you. I'm having some issues with Microsoft Teams. So I can see my slides, but I can't see you. So please just interrupt me if you have questions. And I know that this has been a very long day for you, and you've been engaging in multiple talks. So I decided to do things a bit differently this time and talk for about 20, 25 minutes tops. And then I'm going to open it up for questions. And I hope that maybe we can have a discussion about the topics that I'm going to mention in my slides. So I'm going to focus more on giving you more of an overview of common misconceptions and opportunities in leveraging digital technology to adapt the delivery of interventions. And because, like I said, I want this session to be more engaging, I'm going to focus on recommending some readings that you can go to and explore if you want to learn more about these topics. But I'm going to keep the discussion at a relatively high level. So, okay, before I start, I wanted to thank my amazing, amazing collaborators, including Vivek, who's been very, very kind to train me over the past, I would say, more than 10 years. It sounds like a long time. And you'll see that most of the examples that I'm going to use today, they're based on a program of research that Vivek and I have been developing with Susan Murphy on helping older adults brush their teeth, engage in oral health behaviors. I also want to thank NIH for funding this work. And these are the 6 misconceptions that I'm going to talk about. And I'm going to start with the first one. And this is about just-in-time adaptive interventions and standard adaptive interventions being the same thing. So just-in-time adaptive interventions, those of you who are familiar with the acronym that we're using, JEDIs, and I know Donna Metz, who we all love and adore, she calls them JETIs, but we call them JEDIs for obvious reasons. And many investigators think that JEDI is the same as a standard adaptive intervention, and they're not the same. And to explain why, I think that the first thing that we need to understand is, what do we mean by adaptation? Okay, this concept is defined in so many ways in different fields. And in many cases, people are using the term, but they're not defining it. So, and by the way, you'll see that most of my focus today will be on providing clear definitions for key terms, okay? And if there's something here that you feel like I didn't define well, just let me know. So what do we mean by adaptation? Adaptation here means the use of dynamic information about the person to decide whether and how to intervene in practice. And the question is, why do we need to do that? Why do we need to adapt? Why do we need to use dynamic information about the person to decide whether and how to intervene in practice? And I think the key reason is that we want to be able to address not only the unique, but also the changing needs of people as they progress over time. Now, in standard adaptive interventions, or what we just call adaptive interventions, the goal is to address conditions that change relatively slowly over time. And when I say slow, and I know slow and fast is relative, when I say slow, I mean over a few weeks or every few months. And that's why in standard adaptive interventions, the adaptation happens on a relatively slow time scale. And these interventions, they typically guide the adaptation of human-delivered components or other components that can be adapted on a slow time scale. And as I said, as an example, I want to use an adaptive intervention. This is loosely based on work that we've been doing to encourage older adults to brush their teeth. And to do that, to encourage them to brush their teeth, what we do is we give them an electronic toothbrush, an e-brush, that they're expected to use twice daily for 2 minutes each. And this adaptive intervention starts with a digital intervention that provides tailored messages on a daily basis based on information from the toothbrush. And then in week 5, we use information about their brushing behaviors over the past 5 weeks to decide whether or not they are not responding If they fail to maintain or improve their brushing behaviors over the past 5 weeks, we classify them as non-responders and we add brief coaching. Otherwise, we do nothing. We just continue with the same initial intervention. So this is an adaptive intervention. Why? Because we have an adaptation process. Look, we use dynamic information about the person's response status at week 5 to decide whether or not to add coaching. And the adaptation here happens on a slow time scale. It happens 5 weeks after program initiation. It's because we're trying to address conditions that change on a slow time scale. We're trying to address early signs of non-response to the digital intervention, which we expect to unfold over 5 weeks. That's why we adapt the intervention 5 weeks after program initiation. Okay, so that's an adaptive intervention. What's a JEDI? A JEDI, just like an adaptive intervention, it has an adaptation process. It also uses dynamic information about the person to decide whether and how to intervene in practice. But JEDIs are special because in JEDIs, the adaptation process happens on a much faster time scale. Every few days, hours, minutes, sometimes seconds. And the reason we want to adapt on a fast time scale is because we want to be able to address conditions that change relatively fast. And these conditions are not just changing fast. In many cases, they change in people's daily lives. That's why JEDIs typically guide the adaptation of digital components that can deliver support in daily life. To make this concrete, I want you to think about the digital intervention from the previous example, okay? And suppose that as part of this digital intervention, every day, twice daily, in the morning and in the evening, we use information from the toothbrush to decide whether or not to send them a prompt. If there's indication that they did not brush their teeth over the past 12 hours, we send a prompt. Otherwise, we do nothing. So we adapt, right? We use dynamic information about the brushing behaviors to decide whether or not to send a prompt. There's an adaptation process. But now the adaptation process happens on a much faster time scale. It happens twice daily. It's because we're trying to address conditions that change relatively fast, twice daily. We're trying to address non-adherence to the brushing regimen, brushing twice daily for 2 minutes. And this non-adherence can unfold twice a day. That's why we adapt on a fast time scale. And so JEDIs and adaptive interventions, they both include an adaptation process. They guide how we should use dynamic information about the person to decide whether and how to intervene in practice. But they're different in the sense that the adaptation happens on different timescales. Slow for standard adaptive interventions and fast for JEDIs because they're trying to address conditions that change on different timescales, slow and fast. All right. Second misconception, that a JEDI is an experimental design. And there's a second misconception that a standard adaptive intervention is also an experimental design, and both are wrong. And to see why, we need to understand the difference between two concepts, an intervention design and an experimental design. What's the difference? An intervention design is the answer to the question, how should practitioners deliver an intervention in practice? And when I say practitioners, what I mean is the entity that delivers the intervention in practice. It can be the coach, the therapist, or the digital technology. An intervention design means what procedures, what guidelines they should follow in practice when they implement the intervention. So what's an experimental design? Experimental design is the answer to the question, how should we, investigators, how should we systematically manipulate independent variables so we can answer scientific questions that we're interested in? In experimental designs, we have randomizations. Why? Because we want to be able to answer causal questions. That's why we randomize. In an intervention design, we have no randomizations because the goal is not to answer causal questions. Actually, the goal is not to answer questions at all. The goal is just to guide the delivery of interventions in practice. And I want you to think about this for a second. When you're trying to guide someone to tell them what you think they should do you randomize them? I hope not, right? You don't randomize them. What do? You give them a protocol to guide them in practice. And that's what these adaptive interventions do, this adaptive intervention and this JEDI. So think about it. This adaptive intervention is just a protocol that guides the coach in when and under what conditions they should come in and deliver brief coaching. And this is a protocol that guides the digital technology and deciding when, under what conditions, a prompt should be delivered. So these are protocols, adaptive interventions and JEDIs. They are intervention designs, not experimental designs, and there are no randomizations in JEDIs and standard adaptive interventions. Okay, third misconception. Oh, that's an interesting one. Adaptive interventions and JEDIs should not be combined. Why not? Okay, why not? Think about it. And I get this really often. People say, oh, I want to design an adaptive intervention, period. I want to design a JEDI. And then you actually realize that they need something that combines the two. And if you think about the spiel that I just gave you, just think about it for a second. What did I say? I said that we want to develop an adaptive intervention that uses information about participants' response status at week 5 to decide whether or not to add coaching. I want to adapt the delivery of coaching on a slow time scale. But what else did I say? I said that we want the digital intervention, this one here, to adapt the delivery of the prompts twice daily based on information from the toothbrush. So essentially, I want to be able to develop an intervention that combines a standard adaptive intervention and a JEDI, and it makes perfect sense here. And this is called a multimodality adaptive intervention, or mHTI, because our team loves acronyms. And you can think about a mHTI as an integration between a standard adaptive intervention and a JEDI. Essentially, it's just an intervention design that guides how human-delivered components that adapt on a slow time scale should be integrated, should be blended with digital components that adapt on a fast time scale. And if you're interested in this kind of intervention design, this manuscript here provides what I hope is an accessible introduction. And it also provides an introduction to a new experimental design, hybrid experimental designs that can be used to answer all kinds of questions about how to blend human delivered and digital components that adapt on different time scales. All right, so should you combine standard adaptive interventions and JEDIs? Depends on the problem that you're trying to solve, the type of intervention that you think can solve the problem. Okay, the fourth misconception. JEDIs should intervene when people are vulnerable. Okay, that's also an interesting one. You see, many investigators, and myself included, I admit, we are extremely excited by this idea of developing JEDIs that intervene when people experience a state of vulnerability in real life. So what is a state of vulnerability? It's a state of high risk for an adverse proximal outcome. Think about craving. It's a state of vulnerability for binge eating. Or stress. It's a state of vulnerability for smoking lapse. Now, the reason we want to intervene when people experience these states is because we want to be able to break the link between the state of vulnerability and the adverse outcome. We want to prevent the state of vulnerability from leading to an adverse outcome, right? It makes perfect sense. So what's the problem? Of course, there's always a problem. The problem is that in many cases, when people experience these states of vulnerability, such as stress or craving, they are not receptive to digital interventions. They are unlikely to engage with the intervention that we deliver. And the best example I can give you is from a study that is called Sense to Stop. This was led by Bonnie Spring, and I was very, very fortunate to be part of the study and lead the data analytics. And this study is a micro-randomized trial that was designed to figure out when is a good time to deliver a prompt to encourage smokers attempting to quit to engage in a self-regulation activity on the phone. Think about a brief mindfulness-based intervention. Is it better to prompt them to encourage them to do that when they're stressed or when they are not stressed? To answer this question, we had participants wear a collection of sensors that monitor their physiology continuously. And there were two algorithms on the phone that used the data to classify every given minute as either stress or no stress. And we micro-randomized to either prompt versus no prompt, sometimes when they're stressed and sometimes when they're not stressed. And the outcome was the likelihood of experiencing stress in the next 2 hours. And guess what we found? This is really interesting. We found that when smokers attempting to quit experience stress in real life, prompting them to engage in a self-regulation activity increases rather than reduces the likelihood of experiencing stress in the next 2 hours. And this adverse effect, we found that it intensified here, became stronger over the course of the 10-day MRT. And we think that it has to do with stress, although it's been a state of vulnerability for a lapse. It's probably also a state in which people are not receptive to the digital prompt. Maybe they're experiencing cognitive overload, so they can't really process and take advantage of the prompt. So whether or not we should intervene when people experience states of vulnerability in real life is an open scientific question that we should investigate rather than make assumptions about. All right, the fifth misconception, we're almost there. Jedis promote intervention engagement. Okay, let's talk about engagement. I love talking about engagement. Engagement, in my opinion, is not well defined. It seems like we always use that term, but we forget to define it. So in this manuscript, we define engagement as the investment of physical, emotional, and cognitive energies in a focal task or stimulus. Now, if you define engagement in this way, you realize that to measure and understand engagement, we have to answer the question, engagement with what? We have to define clearly the stimuli and the tasks that we talk about. And let me show you an example. Again, this is based on our work. It's a simplified version of Oralytics. That's the app that we're using to encourage brushing behaviors. And look what we do here, okay? This is just to illustrate the issue. In Oralytics, we use data from the eBrush to provide feedback about the participants' brushing behaviors, showing them the quality of their brushing. But of course, they don't access the feedback. So what do? The app sends them prompts from time to time, encouraging them to look at the feedback in the app. And the goal is to get them to engage with brushing behaviors. We want them to use the feedback to improve the quality of their brushing. So I want you to notice what we're doing here. And this is a relatively simple Jedi, okay? We want them to engage with this particular health behavior, brushing behaviors. But to do that, we expect them to engage with the message. They will need to pay attention to the message. They will need to read the message. They will need to click on the message to access the feedback in the app. And then they will need to pay attention to the feedback in the app, process this information, make sense of it, and then use it to improve their brushing behaviors. So we expect them to engage in these collection of stimuli and tasks in order to increase engagement with the target health behavior. So the point here is that Jedis can certainly be designed to increase engagement with a target health behavior, But to do that, I think that it's important when we design Jedis is to map out all the stimuli and the tasks that we want the Jedi to include and make sure that each one of them and the collection is designed in a way that is engaging. Okay, the last one. Oh, it's my favorite. Adaptation is always at the individual person level. Of course, it's a misconception. It can be at any given level, depending on the scientific model that is guiding your intervention development. It can be at the patient level, it can be at the dyad level, it can be at the clinic, the school, the organization, and so on. And I want to show you an example here, again, based on our work. What we're currently doing is working to develop a dyadic Jedi to help older adults brush their teeth. And as part of the Jedi, we are prompting not just the older adult, we also want to prompt the care partner so that they would encourage the older adult to brush their teeth. And we want to prompt the dyad because we want to improve the quality of the relationship between them with the hope that by improving relationship quality, it will indirectly improve brushing behaviors. So notice that we're not just targeting the individual, we're also targeting the care partner and the dyad. And it's because the scientific model that we use to guide intervention development highlights mechanisms of change that we should target, not just at the older adult, but also the care partner and the dyad. And that brings me to my conclusion, because I actually think that all the misconceptions that I just described can be resolved or minimized. If we investigators, if we start the process of designing an intervention by clearly specifying the conceptual or scientific model that defines the distal outcome, the ultimate goal that we're trying to achieve, and outlines mechanisms of change through which we think that our interventions can facilitate the desired change or lead to the desired change in our distal outcome. And this kind of model can help us understand how fast we should adapt, with what modality we should adapt, at what level, but it can also help us understand what are the scientific questions that we have, what open scientific questions we have, we need to answer in order to develop a high quality intervention. And based on identifying these scientific questions, we can select different kinds of experimental design studies that can help us answer these questions. So I'm going to conclude by saying that our website includes tons of resources that you can use to design adaptive interventions and Jedis, to select an experiment to answer questions about these kinds of interventions. There are also software and other resources that you can use to analyze the data. So please check it out if you are interested in this area of research. And this is all I've got. I'm happy to open it up for questions and discussions, whatever you want to do that would be helpful to you.
Wonderful, Billy. Thank you very much. I'll open it up to the scholars. Let me begin, if I may. I was intrigued. Bonnie presented some interesting data about health promotionists. And have you thought about kind of using hybrid human-in-the-loop models with them as kind of semi-autonomous nodes in the adaptive loop?
Yeah, definitely. And I think there are various ways to go about this, but I think that at the end of the day, any integration of human-delivered and digital components would require testing, would require investigation, because I don't think that we really know how to best blend these two modalities. So I think whatever we decide to do in this direction has to involve clearly specifying what kind of scientific questions we want to answer and then figure out how to move forward. Does that make sense? Like, I feel like at this point, we can't really commit to doing this one way or another. It's just that we don't know.
Thanks. Scholars, this is your time to worship at the altar of Billy.
I have a question. Thank you, Willie, for giving us such a nice presentation that is adaptive intervention. So I have two questions. One question is, do you have any plan for adaptive intervention, that kind of like project with the regular toothbrush, including the regular toothbrush and providing any feedback from the regular toothbrush also along with the electronic toothbrush, that you're providing the 12 hours cycle, then do the brush or do the forget the toothbrushing. Uh, and the second question is, do you have any plan to include micro toothbrushing activity, like provide a summary, do the forget upper teeth toothbrushing or lower teeth toothbrushing or center brushing, like a weekly summary or day-wise summary or that kind of thing.
That's actually a question, and both questions I think are for Vivek, but I'm gonna try. Okay, so I'm gonna talk about this from the perspective of the intervention design, and then Vivek can talk about the science behind it. But for the first question, the regular toothbrush, this is interesting because I think it brings back an interesting tension between delivering an intervention to support the individual and introducing burden that could lead to disengagement. And the reason I'm saying this is because trying to figure out whether or not they brush their teeth with a regular toothbrush requires asking them, because how do you know, right? The regular toothbrush doesn't have sensors. The e-brush has sensors, and it reduces the load on participants that they would need to have if they had to report their brushing behaviors. So I think that we ended up to balance that load, because we also wanted to know if they're using the regular toothbrush and not just the e-brush. We ended up integrating, I think it was weekly questions, Vivek, but we added self-reported items to the intervention in such a way that would not assess brushing behaviors with the regular toothbrush frequently, but enough for us to get a sense of whether or not there's an overlap between using the e-brush and not using the regular toothbrush, and vice versa. Does that make sense? So that's for the first question. And now I forgot the second question. Can you remind me?
So from your presentation, you provide the feedback, do the brush or not, like
Yeah.
within
Oh,
two
yes.
times
Oh,
in a
this
day.
was a good question. Yeah, the feedback. So I think the feedback that they get is actually has multiple modalities to it, and Viva can speak to that a little more. There's feedback that we provide in the app that they can access on demand about the quality of brushing. There's also a delay in our ability to gather that information and provide that feedback. So there's a delay between getting the information from the sensors and showing it in the app. But at the same time, the toothbrush provides feedback in real time. So if you use the e-brush, it tells you when you finished brushing one quadrant and you need to move to another one. I think the base also tells you a little bit more about the quality of brushing for each quadrant, but I can tell you that I fail to look at the base when I use it. Vivek knows this. So there is information that they get in real time that they can use to modify the way they're brushing. But I think with both types of feedback, the feedback that they get in real time and the feedback that is a bit delayed on brushing on the phone, there are advantages and disadvantages, right? So one disadvantage is what I just said, like in real time when you brush your teeth, it's hard to pay attention to the feedback that you get from the base, right? So that's a disadvantage. An advantage is that it can, if you do pay attention to it, it can help you improve brushing in real time. The feedback that you get on a daily basis or twice daily basis, it's more comprehensive. That's the advantage. But the disadvantage is that it's delayed. It's not in real time. So I think you have to, when you design an intervention like that, you have to think about the balance between the advantages and disadvantages. Does that make sense?
Yes, thank you.
It's a
Thank
good
you.
question. Complicated answer. I realize that.
Billy, we have three people lined up at the podium. So they're all thinking about ways they can apply your learnings to their particular health conditions they want to tackle. Jackie, you want to go first?
Sure. Thank you so much. Thank you for that amazing presentation, Billy. I think adaptive interventions are so cool. And so, in your diagram, in that kind of bifurcation where you decide whether your non-responder will now be exposed to health coaching.
Mhm.
Can you talk a little bit about your approach to deciding what that additional component may be? Because I find that sometimes we may jump into health coaching when there might be other sort of barriers that we might not be considering. So, for instance, I'm doing an mHealth SMS intervention to improve diabetes medication adherence in a Spanish-speaking population, and we're increasingly finding that one of the biggest barriers is that patients can't read their prescription labels. And so, we could have potentially designed an adaptive intervention, assuming that the non-responder will benefit from more written content, when in fact, we may need like an auditory component or something like that. So I'm just like curious, how do you really design that sort of adaptive arm for the non-responder, kind of, considering that there's sort of like a myriad of potential upstream barriers?
Yeah, absolutely. The first question I'm trying to ask myself is why? Why aren't they non-responding? Right? What is the key mechanism underlying non-response? Is it disengagement? Is it not reading the labels? Is it dissatisfaction? Is it low self-efficacy? Is it low motivation? What is it, right? And sometimes you have data to indicate that, and sometimes you don't. So you have to collect data, because if you don't know why people are not responding, how do you design the subsequent intervention? The subsequent intervention has to address non-response. So for us, in our case, the assumption that we're making is that the key mechanism driving non-response is disengagement. It's low engagement. It's really hard to engage with the digital interventions alone without some human touch. So Vivek and we realized that maybe a way to increase engagement would be to bring in some low human touch to this digital intervention. And by that, we'll be able to get more people in the right course. In your case, it might be a different reason. And based on that reason, you can figure out what kind of intervention you want to deliver subsequently. And if you don't, I suggest conducting a study that will help you figure this out. Sometimes it's enough to talk to participants and ask them and say, okay, what was the problem? Why this did not work for you? And based on that, I would say a combination of qualitative and quantitative data would be the best way to approach it. Does that answer your question?
Yeah. Thank you so much.
Rita, you're next.
Thank you, Billy. This is Rita and fellow ISR graduates. And I'm particularly interested in a lot of the relationship building aspect and then the multi-level kind of going above with the individual level that you're talking about. And I'm particularly curious, like if you can help us imagine, I mean, one, elaborate a little more on the relationship aspect building of the partnership, that how can that happen? Through just in time and as well as kind of you were mentioning about across multiple levels. So if you have any thoughts to help us kind of imagine how can those happen?
Oh, I have a lot of thoughts. So Vivek knows. I have a lot of thoughts, but all are conjectures, just so you know, because I think when I'm thinking about the next 10 years for me, if I'm lucky, is to build a research program that focuses on developing JEDIs for dyadic relationships. This is something that I'm really interested in, because I think that JEDIs are very powerful, but having Jedis that actually leverage social relationships and improve social relationships is key, because I mean, we human beings, we don't live in isolation, and we need to have people around us to support us in order to be able to improve in certain directions. So I can tell you that right now we are engaged in a pilot project that gathers information from older adults and care partners to try and figure out how we can support them, how we can support the dyad. But before I tell a little bit about this, I wanted to emphasize that remember that model that I showed you in the last slide? And I just need a reminder, Shaheen, if you can remind me to make a PDF out of it, and I'll share it with all of you. It's actually, I put it in a paper that is currently in press in Annual Review of Psychology with Susan Murphy, and it's supposed to be some sort of a template for a conceptual model that can guide the development of dyadic Jedis. So you can see my line of reasoning, right, for choosing to focus on specific mechanisms and not others, and how I structured it. Like, what's the process? I actually provide some guidelines on the steps that you can take. This is all based on the work that we've been doing, because I struggled with this. What's the best way to figure out how to develop these dyadic Jedis? What are the steps that we can take? So they're described in this manuscript if you're interested. It's in press, but if you want it, I can send you a copy. Just send me an email. So we started with outlining this model that you can see in this manuscript. And obviously I had assumptions. I reviewed the literature and I had lots of assumptions about the mechanisms that could facilitate positive behavior change at the older adult, the care partner, and the dyad level. And interestingly, then we went to do some focus grouping with older adults, care partners, and dyads. And what we learned from these focus groups was quite interesting, because some aspects validated the way we were thinking and some aspects completely did not. They revealed some, really interesting insights that I didn't think about when I designed it initially. So because I had certain mechanisms in mind based on the literature, I wanted to design components in a certain way to facilitate the high quality relationship. And I can share with you that some of the components that I thought were based on reciprocity. So they could send each other prizes and inspirational quotes to encourage each other, to brush together and separately. And in the focus groups, we realized that the problem is very different. The problem is that they want to support each other's brushing behaviors, but they're not aligned in terms of how well and whether or not actually the older adult brushed. So the older adult thought that they brushed in a certain way in terms of frequency and quantity, and the care partner had a different perception of it. And there was this misalignment that was really hurting not the relationship, but also their ability to shape the behavior. And that's the key problem that they highlighted in the focus groups. And that was really, to me, it was really shocking. The reason I'm telling you this story is that the existing literature can send us in a certain direction. I think that engaging the target population in designing, not just designing the intervention, but also coming up with the scientific questions, shaping your scientific question is really critical. And that's just one example for how important it is. Bottom line, I would start with a scientific model. That doesn't mean that we shouldn't go to the literature and review it and summarize it. And I hope that these template models in this paper can help you. But I think then we always have to go to our population and engage them to see if we have misconceptions about what is actually driving the behavior change or could drive the behavior change. I know maybe it wasn't the answer you were looking for, but I think that participatory research is really critical when we're doing work in this area.
Thanks, Billy. Just by context, the older adults have dementia and early Alzheimer's. So it's a very complicated dynamic that we had not completely understood until we got into the focus groups. Erin, you have been waiting patiently.
Hi, I'm Erin Bange. Thank you for your talk. And my question is like kind of overlaps some of the themes that we've brought up already and is somewhat a little bit adjacent, just again, selfishly for some of the work that I'm doing. And so I have some ongoing projects looking at mHealth initiatives in older adults. And what I've seen is this kind of gap in terms of ability to engage. Like there's some who are really great. You can like almost just ship a device to them and they can get it all set up themselves, no help at all required. And then there are others who really, really struggle. And you need to have probably in-person support, at least up front, to be able to engage. And it seems like the intervention you have here is quite sophisticated, especially thinking about somebody who may have dementia, and that they need to use the device correctly. They then need to engage with the app appropriately to take away the lessons from it, and then apply those lessons. And I'm just wondering, as someone who has ongoing projects in the geriatric population, how have you navigated that kind of? Have you seen that range, and then how have you navigated and have your adaptations kind of incorporated that as well?
Yeah, so I think that different JEDIs should be designed depending on the level of cognitive decline that older adults are experiencing. And there's no one size fits all when you're talking about older adults with cognitive decline. And we have to be really careful about that. So I think that it's important to clearly define the target population that you're focusing on and their capabilities with respect to digital technology and design the intervention around it. That's how I would approach this. But it is a really important problem. And just so you know, for projects where the focus is on older adults with severe cognitive decline, what I currently see is the investigators being mainly interested in supporting the care partner and helping the older adult perform the target behaviors. So then the JEDIs now, they are less focused on the older adult. Now they're focused on the care partner.
That makes sense.
Scholars, any other questions?